Clinically relevant Apicomplexans and Microsporidia. So starting with Apicomplexa, the phylum Apicomplexa includes blood and tissue parasites. These groups of organisms show a diversity of morphology and transmission methods and can infect many different body sites. The life cycles are complex, characterized by sexual reproduction and asexual reproduction. Some of the members of Apicomplexa may require an insect vector or intermediate host for completion of the life cycle. Humans can serve as a definitive host when sexual reproduction, offspring arises from the exchange of genetic material between two parents, occurs in human tissues, and as intermediate hosts when asexual reproduction occurs. So starting off with Plasmodium. Plasmodium causes malaria, and there's 5 different species that are relevant here. So Plasmodium vivax, ovale, malariae, and falciparum are the 4 main ones. And then Plasmodium noalsi originated in simian species, in other words, primates, now associated with human malaria. They're endemic throughout the world in tropical and subtropical countries. Along with schistosomiasis and amoebiasis, malaria is a major cause of death in people in underdeveloped countries. Geographic distribution, Plasmodium vivax is widely distributed, most likely to be found in temperate climates, P. ovale, western parts of Africa, P. ovale and P. falciparum throughout Africa and in the tropical countries, responsible for more than 95% of infections. So this is a map showing the geographical distribution. So you can see the different colors here, and then they're like pie charts that say the percentage that you would find in the different regions. So I strongly encourage you to take a look at these and determine where you'd find the different organisms. Now on this map, it doesn't show anything in the United States. However, we are starting to see a few cases of malaria pop back up in the southern United States. Now, malaria was eradicated from the United States due to the development of a special type of insecticide that contains DDT. Now, DDT is found in different types of mosquito repellents and that type of stuff. So as we started to create these new mosquito repellents, we basically eradicated the Anopheles mosquito from the United States. And the Anopheles mosquito is the type of mosquito that can transmit the Plasmodium parasite. We started to notice a drastic decline in the number of our predator birds. So our predatory birds are going to be like eagles and hawks and falcons. And we investigated what's going on with these birds and found that their shells had been thinning. So because they developed thin shells to their eggs, every time that they would fly away from their nest and come back, they would sit on their eggs and basically crack open their eggs, killing their babies. So the numbers started to drop drastically. And eventually that was linked back to the use of DDT in the mosquito repellents. So we have now banned the use of DDT in mosquito repellents because of this, but now we're starting to slowly see a lot of the Anopheles mosquito make its way into the southern United States. And along with the Anopheles mosquito being present, sometimes they're carrying that Plasmodium parasite. Now, this is still considered extremely rare to get this type of infection in the United States, but it's becoming a little bit possible. So routes of transmission, it's usually transmitted, like I mentioned, through the bite of an Anopheline or Anopheles mosquito. Other routes would be a blood transfusion, infected needles, transplacental infection has been documented. So the organism is sequestered in the placenta and can compromise fetal development because it affects the transplacental transport of nutrients. So now we're going to look at the life cycle. And out of every organism that we're going to talk about in this lecture, the Plasmodium life cycle is something that you do need to know the details of. So I'm going to take some time on this slide, and then I'd also like you to pause and kind of review the slide on your own and study this, because this life cycle is important to know. There's going to be a lot of targeted questions about this on your qualifying exam, as well as on the upcoming exam for this class. So we start with step 1. And we can really start anywhere, but if we start here with the mosquito taking a bite, a blood meal, so when a mosquito sucks blood from you, they also eject anticoagulant from their saliva. So when they puncture your skin with the needle of their mouth part, they puncture through and they want to be able to suck your blood up like a straw. If your blood is starting to clot, they can't get the blood to be sucked up properly. So what they do is they actually spit into you. And when they spit into you, they spit their saliva, which contains an anticoagulant. And then that allows them to freely feed on your blood. If this mosquito happens to be also infected with the Plasmodium parasite, it can then spit the parasite into you along with that saliva. So as it does that, it's going to then transmit the parasite. The parasite's first journey in your body is to go to your liver cells, your hepatocytes. So that's kind of the first extra erythrocytic cycle. That's the first kind of phase of infection here. It's going to go into your liver cells, and then it's going to infect the liver cells. It's going to turn into a schizont, where it's going to replicate and make many copies of themselves, and that schizont is going to be basically an encapsulated pocket of Plasmodium parasites that have replicated. Then it's going to cause the rupture of your liver cells. So your liver cells are going to rupture open, releasing merozoites into the bloodstream. From here, it's going to then enter the erythrocytic cycle. In the erythrocytic cycle, those merozoites that just ruptured out of your liver cells are going to then enter into your blood cells. Once they're inside of your blood cells, they are going to transform into this ring stage. And the ring stage is an immature trophozoite. From the ring stage, they're then going to mature even further to a mature trophozoite. And there's two different paths that it can take once it's a mature trophozoite. It can then start to replicate. And if it does start to replicate, what's going to happen is this red blood cell is going to become really heavy and sticky. And it's going to stick to the inside lining of your blood vessels. And when it sticks to the inside lining of your blood vessels, it can then rupture. And a lot of times you'll get, especially in like Plasmodium falciparum infections, which is one of the most deadly kind of infections, you'll get many of these red blood cells that are infected and sticking to the inside of your blood vessel walls. Now it seems like all at once these red blood cells will rupture and release the parasite into the bloodstream. So up until this point, if we go back to like the liver stage, once it's in the liver, you do have some generalized pain in the liver. Sometimes you can see a little bit of liver swelling, also known as hepatomegaly, basic flu-like symptoms. But once it gets into this erythrocytic cycle, this is when you're going to have massive symptoms. So, and it's going to be cyclical. So as they're causing your red blood cells to stick to your blood vessel walls, it may cause the occlusion of blood flow, so it may mess with your blood flow a little bit. But other than that, it's not going to cause any major symptoms while those are inside of your red blood cells. Then all of a sudden, all at once, they are synchronized to rupture, and all these red blood cells will break open, releasing all of these merozoites back into the bloodstream. And when they're freely floating through your bloodstream, they're going to cause the drastic symptoms of severe shaking and convulsions. That's something that, having been to Africa and having heard like what actually happens to malaria patients that have this, it is extremely severe. So these convulsions, these shaking spasms are uncontrollable, and that's what kind of elevates this from like your typical flu. So it also distinguishes this guy from like other types of apicomplexans, like infections with babesia, where babesia we'll talk about next, but that one kind of looks like the same type of form as malaria, completely different symptoms. You don't see that that cyclical rupturing and those convulsions. So what happens in this portion here, if we're talking about the erythrocytic cycle, like I said, these are going to become really big. They stick to your blood vessel walls, and then they do this synchronized rupture where these things are going to be released into the bloodstream. And at that point, you have a major spike in inflammation. Cytokines really mediate this process, and you have pro-inflammatory cytokines which promote inflammation, and you have anti-inflammatory cytokines which decrease the inflammation. So you have a strong surge of pro-inflammatory cytokines, and that's what kind of causes all of these abrupt symptoms to happen. Then they're going to go back inside your red blood cells, and then things kind of calm down. So then you're like, oh, okay, that was crazy. I just went through some major convulsions and high fever and had all these crazy symptoms, and now it seems like I'm fine. So then the cycle kind of continuously repeats where, depending on the species, it could be 2 to 4 hours, it could be 12 hours later. You're going to have that synchronous rupturing from your red blood cells. It's going to cause the massive spike in convulsions and shaking and high fever and high inflammation. And then all of a sudden it's going to calm down and then go in that cycle. Now, if this is occurring inside of the blood vessels in your brain, that's when it can lead to cerebral malaria. These parasites can actually get into your brain tissue and cause seizures, and major complications can lead to death. And the species that usually does that is the really bad guy, Plasmodium falciparum, and we'll talk about the differences as we go through the rest of these slides. But every type of Plasmodium has a slightly different kind of symptomatic expression. All right, so mosquito spit it into you, went to your liver, messed with your liver cells, it replicated in your liver cells, caused those liver cells to die and rupture open, released them into the bloodstream. Now that they're in your bloodstream, they kind of go through this cycle of growing, turning into this sticky blob that's going to stick to the surface of your blood vessels and replicate and then release a whole bunch of merozoites back into the blood. In addition to this cycle, sometimes some of them can also start to form gametocytes. So it can turn into these gametocytes, and eventually it can mature into gametocytes that can then be sucked up by the mosquito. In Plasmodium falciparum, they have these large elongated gametocytes that are sometimes referred to as banana-shaped gametocytes. So on the qualifying exam or on quizzes or tests for this class, if you hear about a banana-shaped gametocyte, we're talking about Plasmodium falciparum. There's some key terms that if you just remember those key terms, you'll do well on the questions that you're most likely to encounter, and that's one of those key terms that, I've been mentioning key terms throughout the course. This is one of those, the banana-shaped gametocytes, so that's Plasmodium falciparum. But other species can form these gametocytes, and the gametocytes are then going to be sucked up by the mosquito when they take their next meal. It's not the same mosquito. It could be a different mosquito. But if you're infected with the Plasmodium parasite and gametocytes are present in the bloodstream, when a mosquito sucks your blood, then they can get the gametocytes from the blood. Once inside of the mosquito, you've got microgametocytes and macrogametocytes. And the micro ones are going to enter into the macros, and this is the sexual reproduction. So the sexual reproductive cycle actually takes place inside of the mosquito. So in this case, the mosquito is the definitive host and the human's just an intermediate host. So then it's going to replicate, it becomes an oocyst, and then it releases the sporozoites, and eventually those sporozoites can then be taken up to the salivary glands of the mosquito, and then the mosquito bites and continues that cycle. So a lot going on in this cycle, but a lot of what's going on in the human correlates to the symptoms. When it's in its liver stage, it's kind of generalized fatigue, may have slight swelling of the liver. In severe cases, you can see pigmentation that kind of extends into the urine. And then you see the blood stage. And the blood stage, depending on how many blood cells are infected, can start to cause the extreme symptoms. Now, if you think about what the purpose of your blood is, or your red blood cells, it's to transport oxygen. So if you're having a lot of your red blood cells get ruptured open and break apart, there's no way that you can regenerate those red blood cells as fast as you can, or as fast as they are breaking apart from the parasite. So people who do have malaria have extreme fatigue because they're not transporting oxygen, so they can't do that aerobic respiration as much as they used to be able to do. The other thing is the convulsions themselves cause extreme fatigue, and sometimes the convulsions and seizures can be triggered just by the high fever that these things cause. Very high risk of death in the pregnant women and in children and in immunocompromised, or if you have any underlying health condition, very high likelihood of death for certain species of malaria. So here's a diagram of the different life cycle stages that you can take a look at. So the malarial paroxysome, 10 to 15 days after the bite of the infected mosquito, associated with the growth of the parasite in red blood cells and the release of high levels of cytokines. So I talked about cytokines, how there's pro-inflammatory ones, anti-inflammatory ones. Typically, when we want inflammation to progress, we use the pro-inflammatory cytokines. Inflammation is a good thing up to a point. So inflammation does call red blood cells to the area. It does increase temperature to try to unfold proteins of the pathogen. It really does try to promote the clearance of the pathogen. But at some point, if we maintain a pro-inflammatory state, if we're in a constant state of inflammation, we're going to start destroying our own tissues and having our own destruction. So that's where we want those anti-inflammatory chemicals or cytokines to come in and kind of stop the inflammatory process from progressing. And it is a delicate balance between pro-inflammatory and anti-inflammatory cytokines that we have to maintain. Now, the Plasmodium parasite has been demonstrated to be able to modulate the types of cytokines that are present during different stages of its cycle, and it's able to modulate them to its own advantage. Symptoms are linked to the rupture of red blood cells and release of merozoites, the parasitic forms produced from multiple fission, malarial metabolites, and endotoxin-like substances into the bloodstream. There are 3 phases. The prodromal phase involves headache, bone pain, nausea, and or flu-like symptoms. In the first phase, the patient experiences a shaking chill lasting 15 to 60 minutes. Shaking chill, meaning that their whole body is vibrating for 15 to 60 minutes. The second phase is characterized by a fever up to 40 degrees C, along with headache, myalgia, and nausea lasting 2 to 4 hours. The myalgia, the muscle pain, likely because of the prolonged shaking and convulsions. In the third and final phase, the fever finally breaks. And then you're kind of like, oh, that was kind of crazy. I'm back to normal. And then the cycle starts again. Over the course of 2 to 4 hours, the patient begins to sweat profusely and is left exhausted and sleepy. This cycle repeats itself at regular intervals depending on the species of malarial organism present as the parasites exit the infected red blood cells. So as I mentioned, when we're seeing that rupturing of the red blood cells, we're going to see those cycles continue. Anemia associated with malaria, the result of lysis of erythrocytes, removal of infected cells by the splenic macrophages, and in some cases, immune clearance of erythrocytes coated with immune complexes of the malarial antigens and antibodies. Long-term infection with any malarial organism may result to damage in the liver and spleen caused by deposits of the malarial pigment, hemozoin. P. vivax and ovale infections generally do not have the range of complications that's seen with other species because the organism invades reticulocytes. There's generally low levels of parasitemia. However, the persistence of hypnozoites that remain dormant in the liver can relapse within 3 years of initial exposure. P. malariae infections can lead to nephrotic syndrome, which arises from the deposition of circulating immune complexes of malarial antigens and antibodies in the basement membrane of the glomeruli, causing an autoimmune-like reaction. This organism has the most chronic course, and recrudescence occurs after decades after the initial infection. The most severe form of malaria is caused by Plasmodium falciparum. Up to 50% of erythrocytes may be infected. Imagine half of your blood cells having a parasite inside of them. You won't be able to effectively transport blood or oxygen around the body because the red blood cells are going to get weighted and sticky, and they're going to stick to the surface of those blood vessel walls. You're going to need massive red blood cell replacement. Between 20 and 50% of deaths are caused by Plasmodium falciparum are the result of CNS complications. A second but less complication of the infection with P. falciparum is black water fever, characterized by hemoglobinuria, hence the term black water. So that's hemoglobin in the urine. Usually develops in patients with repeated infections and those undergoing quinine therapy. So quinine is one of the drugs was used pretty predominantly, and now they've switched to more of an artemisinin-based therapy. And artemisinin is a different kind of drug, but they combine it with another type of drug. So there's artemisinin combined with chloroquine, or artemisinin combined with mebendazole. So there's different types of combination therapies and protocols that exist. But due to the rapid increase of antimalarial drug resistance that we see in the Plasmodium parasite, it's not okay to just give one drug anymore. Typically, it comes with 2 drugs. Blackwater fever may be mediated by an antigen-antibody reaction caused by the development of the autoantibody to red blood cells. Chloroquine remains the primary drug for prophylaxis and treatment of malaria. So chloroquine is readily available. It's distributed by different health organizations, and that's kind of the go-to drug. It's effective against all asexual stages of malarial organisms and all gametocytes except for falciparum. There's emerging evidence of diminished response to chloroquine treatment in patients with Plasmodium vivax. Chloroquine-resistant Plasmodium vivax may be treated with mefloquine or quinine sulfate with doxycycline. Now, here's the thing about doxycycline. You may have heard of doxycycline because that's commonly prescribed in the United States for acne. So when we traveled to Kenya, I did go with my roommate, and my roommate in college had severe acne, so she was on doxycycline already. And when I was looking into different types of prophylactic drugs, because when you travel to malaria endemic areas, typically you want to have some type of prophylactic drugs so that if you do get infected, there's a drug on board to prevent you from actually developing symptoms. Doxycycline was the drug that they told us to take. So my roommate already had it and she was already protected. I just had to get my own prescription of it. Other types of things when you travel to malaria endemic areas are using mosquito repellent. So I brought a ton of mosquito repellent with me. Mosquito repellent is not readily common. Like, they don't really have it in malaria endemic areas because it's kind of pointless. Like, that's a parasite that they all live with and they've all come accustomed to living with it. So typically if you're traveling to those areas, you take some mosquito repellent with you, but they usually don't just have it. They also don't do prophylactic drugs. They take drugs if they're having severe symptoms that aren't going away, but a lot of times they just kind of deal with it and live with it. When I went, every person that lives in Kenya that I talked to had malaria multiple times in their lifetime, and there's a lot of different forms of, even if you get infected with Plasmodium falciparum, there's different like subtypes where you can repeatedly get infected and reinfected and reinfected. There's no lasting immunity once you've already been exposed to malaria. Primaquine phosphate, which is effective against hypnozoites that persist in the liver, is used to treat individuals infected with P. vivax and ovale to prevent relapse of these infections. There's also evidence that some strains of P. vivax in geographic areas of chloroquine resistance may be refractory to primaquine. Artemisinin-based drugs have been used in combination with classic drugs in areas in which highly resistant strains of P. falciparum have emerged, so different regions within Africa. The level of parasitemia should be calculated as a percentage before and during treatment to follow the effectiveness of the treatment. So you want to get a percentage of parasitemia or a level of parasitemia to ensure that treatment is working. Because there are so many resistant strains now, we really do have to monitor and do numerous blood draws to determine parasitemia or parasite load to see if the treatment that we're giving is working. In cases of high parasitemia, a red blood cell exchange may be used before treatment to decrease the level of parasitemia and increase the effectiveness of the drug. So that means we're putting in red blood cells from outside the body. Important patient information to aid in laboratory diagnosis, travel history. It's very important to know which part of the country they were coming from or they traveled from. And the presence of clinical symptoms, malaria paroxysm and fever and chills, because that's going to help distinguish it from babesia or other types of apicomplexan infections. Preparation and examination of both thick and thin Giemsa stain slides are recommended. So a thick smear is just going to give you a basic overview. Are there parasites here? A thin smear is going to allow you to differentiate it on the species level. And the more you get accustomed to looking at different types of malaria slides, the more likelihood you are of actually differentiating the species. Other microscopic immunoassays are available. And then here's just a chart that compares the four main malarial species. You can pause the video and take a look at this. Laboratory diagnosis. Again, the thick smear is used to detect malaria parasites. Distortions of the parasite's morphology and lack of intact red blood cells require a thin smear to be examined to identify the species. Trophozoites, schizonts, and gametocytes may be seen in the blood smear. More than one set of smears should be made within a 36-hour period because one set is inadequate to completely rule out the presence of malarial organisms. Think about the life cycle. So as I mentioned, when they leave the liver, they're going to go inside of your red blood cells. And when they're inside of your red blood cells, sometimes those red blood cells will get weighted and sticky, and they'll actually stick to the inside surface of your blood vessel walls. If all of the infected blood cells are sticking to your blood vessel walls, then the circulating blood cells are not going to have any parasites in them. So if you do a blood draw and you see no parasite in the circulating red blood cells, it doesn't mean that the person doesn't have malaria. It just means that the stage of infection isn't at that time going to allow you to see them. So that's why we typically need more than one blood sample. In addition, we can take the blood sample and look for the levels of different types of cytokines. So if there's pro-inflammatory versus anti-inflammatory cytokines, we can correlate those as we would anticipate toward the end of a malarial infection, we would see more of the anti-inflammatory cytokines. The QBC system using fluorescent dye, acridine orange, is a sensitive method for demonstrating the presence of parasites. A thin smear must still be examined for the definitive identification of the Plasmodium species. Nucleic acid amplification tests have been proposed as another method for diagnosing malaria. The problem is, in endemic areas, they don't have access to this type of technology. It's super expensive. They do have a good sensitivity in detecting low levels of P. falciparum, though. But extended time, costly equipment required do not make the procedure cost-effective or efficient, especially for field work. Several different immunoassays, collectively referred to as RDTs, use malarial antibody impregnated dipsticks to detect Plasmodium infection. These assays use an antigen capture immunochromatographic principle to detect soluble proteins from malarial organisms in the blood. Some tests use a monoclonal antibody directed against an antigen specific to P. falciparum, histidine-rich protein 2. Other tests use an antibody that detects a protein common to all species, parasite lactate dehydrogenase or Plasmodium aldolase. Serological tests for antibody to malaria are not useful in endemic areas because it's most likely that someone's been exposed previously, so having antibodies against malaria in an endemic area is not unlikely or uncommon. But it could be useful in diagnosis for those who have traveled to an endemic area to see if they've been exposed to malaria. Testing for the presence of hemozoin in the blood is an emerging area of malarial diagnostics. So this is a really good chart that kind of shows you side by side the differences. So the ring form, trophozoite, the schizont, and gametocyte. And it tells you some differentiating features here. So a couple things that I can point out here is for Plasmodium falciparum, you're usually going to find multiple ring forms within the blood cell, as opposed to Vivax, malariae, and ovale, which you typically only have one form. Now, Noelsi, we didn't talk about yet, or I mentioned it briefly, but that's the one that mostly infects primates. That's going to look a lot like falciparum. Plasmodium vivax, you're going to see enlarged red blood cells, and you're going to see the amoeboid-shaped trophozoites. So different types of features here are laid out, and you can kind of read here to see those differences. So just going through these species one by one. Plasmodium vivax, the tertian life cycle pattern. Life cycle takes approximately 48 hours to complete. Invasion begins on the third day. P. vivax usually invades young red blood cells, reticulocytes. Therefore, it's characterized by enlarged, infected red blood cells, often up to double the normal size. Infected red blood cells may contain pink to red staining granules. Schuffner's stippling. So if you see which one of the species contains Schuffler's dots or Schuffner's stippling, That would be related to Plasmodium vivax. The young trophozoite is characterized by its amoeboid appearance. By maturity, it usually fills the red blood cell and golden brown malarial pigment is present. Schizonts contain 12 to 24 or more merozoites. Average is 16. Gametocytes are rounded and fill the cell. Macrogametocytes are often difficult to distinguish from mature trophozoites. So this is a picture of the different life cycle stages that you may find in the bloodstream. And here you can see an early trophozoite, a mature schizont, and a macrogametocyte. P. malariae, quartan life cycle. Life cycle takes approximately 72 hours to complete. Invasion of new red blood cells every 4th day. Trophozoite, also known as the band form, is compact, characteristic band form, hence the form name. Dark, coarse brown to black pigment is seen in the band form, usually a few pink cytoplasmic dots. Mature schizonts have no more than 6 to 14 merozoites, average is 8. Merozoites are known to form loose daisy petal arrangement. So here you can see P. malariae. And if we compare that to what we're seeing here, you can see a lot more inside of P. vivax than you would inside of P. malariae. And here's a few more pictures. You can see the band form and then the schizonts and macrogametocyte. P. ovale, least commonly seen species. It resembles P. vivax. Infected red blood cells are enlarged and may assume oval shape with fringe-line hairs or edges. Schuster's dots are less common than in P. vivax. Cell stain almost bluish pink. Compact cell and fimbriated cell are characteristic. Has a golden brown pigment. 6 to 14 merozoites in mature schizonts. Tertian life cycle. So here's that color that I was talking about, the bluish color. And here you can see the different forms. P. falciparum, identified as having a tertian life cycle, but often demonstrates an asynchronous life cycle. Rupture of red blood cells takes place at irregular intervals, ranging from 36 to 48 hours. The life cycle stages seen in peripheral blood are usually limited to ring form, trophozoite, and gametocyte. Other forms are in the venules and capillaries of the major organs. P. falciparum invades red blood cells of any age and for this reason often exhibits the highest level of parastemia, reaching 50% in some cases. The ring forms of P. falciparum are more delicate than those of other species and often have 2 chromatin dots. Applique forms, which are parasites at the edge of the red blood cells, and multiple ring forms in a single red blood cell are common. Occasionally, small comma-shaped red dots, referred to as Maurer dots, can be seen in the cytoplasm of infected cells. The mature trophozoite is small and compact and may have a dark brown pigment. Schizont, which is rarely seen in peripheral blood, has 8 to 24 merozoites with an average of 20 to 24. Gametocytes have characteristic banana or crescent shape. So here you can see the ring form. Here you can see multiple ring forms. That's common for falciparum. And then here's that banana-shaped gametocyte. And here are the different forms. And then this is kind of like a quiz, which species is depicted. So you can go ahead and try to figure that out. So a word about P. noelsi. Noelsi has an early life cycle stage that resembles those of P. falciparum. Mature trophozoites and gametocytes that resemble those of P. malariae. Therefore, pertinent information, including travel history to an endemic area, is important in making a diagnosis. So that concludes Plasmodium or malaria. Now we're going to switch gears and talk about Babesia. Intererythrocytic zoonotic parasite causing human infection, generally infected cattle and other vertebrates. Tick bites transmit the pathogen, the Ixodes species. Ixodes species is the same tick that transmits Lyme disease. White-footed mouse and white-tailed deer are the reservoirs. Other modes of transmission, transfusion of contaminated transfused blood. Most cases were linked to red blood cell components. Currently, there are no FDA-approved tests for screening donor blood units for antibodies to Babesia. Congenital transmission has been reported. There have been reports indicating simultaneous transmission of Babesia with Borrelia burgdorferi, which causes Lyme disease, because the two organisms have the same tick vector. In the U.S., most cases appear in the Northeast and Upper Midwest. Patients often manifest clinical symptoms of one disease but show concurrent increase and decreased antibody titers in both Babesia and Borrelia burgdorferi. Several species are known to infect humans. In the United States, it's Babesia microti. In Europe, it's Babesia divergens. So Babesia, causative agent of babesiosis. Most cases of babesiosis occur from May to September. That's when those ticks are high prevalence out there. Infection is often asymptomatic. Populations at risk of infection, the very young, older adults, and immunosuppressed patients. Symptoms are related to the asexual reproductive cycle, lysis of red blood cell, and the level of parasitemia. Time from infection to development of symptoms is 1 to 6 weeks. Symptoms are malaria-like symptoms, and some patients are asymptomatic. Fever is not cyclic as it is in malaria. Anemia may develop if hemolysis is severe or prolonged. The clinical course tends to be more severe or have complications if the patient has undergone splenectomy, is immunosuppressed, or is older. Complications include respiratory, liver, or renal failure, disseminated intravascular coagulation. Treatment. There's a couple different drugs that are listed here. In very severe infections, exchange transfusion may be used. So we may actually have to add additional red blood cells to the patient. As with Plasmodium species, the life cycle of Babesia has alternating asexual and sexual reproductive stages. Production of infectious stages, sexual reproduction takes place in the tick, just like with malaria, taking place inside the mosquito. The zygote migrates to the salivary glands of the tick where sporozoites are formed. These sporozoites enter vertebrates during a blood meal. Now with the tick, in addition to, ticks are pretty large relative to a mosquito. Now there's different types of ticks. There's the nymphs, which are super tiny, and they're about the size of a mosquito, and then there's your standard adult form of the tick. And the Ixodes tick is the deer tick, and the deer tick has a little hood on the back of it. The dog tick is another tick that's pretty common here in Wisconsin. The dog tick is going to have speckles on its back as an adult. So looking for that hood on the back as opposed to the little speckles on the tick will help you determine whether you have to worry about exposure to these kind of bad guys. But the Ixodes tick is the deer tick, and that has that little hood on its back. Now it has to be attached to you typically for 48 hours before adequate exchange of saliva can put you at high enough risk of getting the infection. And that's with Lyme disease or with Babesia. So when a tick bites you, not only do they eject some type of anticoagulant into your skin, they also eject some numbing some numbing chemicals that interferes with your ability to feel that area of wherever it has attached. So you don't really feel the bite itself, and you don't feel it remaining attached because of that numbing chemical that it releases. It blocks sensation in that area, and that allows it to go undetected for a period of time. Inside the cell, they become trophozoites and divide by asexual reproduction, budding to form pairs, tetrads, and the reproduction time in Babesia infection is approximately 4 to 6 hours. The resulting merozoites are released to infect other red blood cells, where they use merozoite surface proteins to attach glycophorin A and glycophorin B on the red blood cell membrane. Some merozoites differentiate into gametocytes, but this is not an easily identifiable stage from the trophozoite. There's no exoerythrocytic cycle in humans. Transovarian transmission can occur in the tick, allowing the life cycle to persist without an intermediate host. Laboratory diagnosis: right or gamma-sustained thin blood smears. The organisms appear small, delicate, pleomorphic, ring-formed trophozoites, prominent chromatin dot, and faintly staining cytoplasm. More mature trophozoites may appear as pyriform organisms, although they're characteristic for babesiosis. The tetrad forms are not always seen. Morphology initially may be confused with that of P. falciparum, but there's different symptoms, so then, travel history and all that kind of stuff would help with the diagnosis. So here you can see what it looks like in a blood smear. Immunological methods may be used, and molecular methods to detect parasite DNA have been developed and may be used when there's a high suspicion, but the smears remain negative. Toxoplasma gondii. Causative agent of toxoplasmosis. It's an obligate intracellular parasite that's found worldwide. As many as 1/3 of individuals may be infected. More than 20% of the U.S. population shows serological evidence of infection, but parts of Europe, the proportion may be as high as 80%. Toxoplasma gondii is the reason for the term crazy cat lady, and it may actually make people crazy. So what happens with this guy is typically you're going to get the spores inside of your body, and when they come into your body, you can inhale them from cat litter box or consume them in infected meat or different ways. When they hatch open, they become this migrating form that can migrate into various tissues in your body. Usually in immunocompetent people, so people who have a fully functional immune system, and people who are not pregnant, there's no complications. So it'll just migrate into your muscle tissue and form a cyst in your muscle tissue. And then it kind of hangs out there and waits. And the only way that this parasite could actually complete its life cycle is if you were to be eaten by a large cat. If you get eaten by a large cat, then the cat can eat those cysts. Then those cysts will reproduce inside the digestive tract of the cat and then be released again in the feces of the cat. But most people don't get eaten by cats. So for the most part, we are dead-end hosts, or we are the end of the road for this pathogen. So it's going to form those cysts, and those cysts are going to stay in your tissues and not really cause any problems. Some people, when they first get infected, can get mild flu-like symptoms, but typically you don't pay attention to them. They're not severe enough to go get looked at or treated for. If these pathogens happen to make their way into the brain, though, they can potentially cause some inflammation and some weird things to happen in the brain and can lead to the development of some neurological symptoms. But typically that's only going to happen in the very old, the very young, and immunocompromised. If a woman is pregnant, and these guys get into the developing fetus, then they can cause some massive symptoms depending on where they implant the developing fetus. If it's early on in pregnancy, it can cause the loss of the baby. If it's later on in pregnancy, sometimes the baby's born with no symptoms and eventually develops symptoms later on as the parasite takes hold in the body. So clinical presentation differs based on the immunological status of the infected individuals. Patients with acute infections may be asymptomatic or may have mild flu-like or mononucleosis-like symptoms, including low-grade fever, lymphadenopathy, malaise, and muscle pain. Once the acute infection has resolved, the organism enters a relatively inactive stage in which the tissue cysts containing many slow-growing forms of the organism are found. May be transmitted congenitally because of transient parasitemia in pregnant women who have primary infection. Congenital transmission occurs when tachyzoites, the motile rapidly dividing morphologies in the maternal circulation, cross the placenta and enter fetal circulation and tissues. Now, if you've had this organism previously, usually it's not a problem and it's not just going to leave your muscles and go kill the baby. It's a primary infection. So if it's the first time you're exposed ever in life, and you get the infection for the first time while you're pregnant, that's when the symptoms can impact the baby. Symptoms in children with congenital infection include intellectual disability, microcephaly and seizures, so smaller than normal brain size. Hydrocephalus would be swelling of the brain due to increased tissue or fluid in the brain. Retinochorditis or blindness, so that's if it gets into the eyes, it can impact eye development. If the fetus is exposed to infection early in pregnancy, more severe complications are likely to result. Infections acquired later in pregnancy may result in the child being asymptomatic at birth, like I mentioned, but eventually they can develop ocular problems later in life. Immunosuppressed patients, Especially those with leukemia, lymphoma undergoing chemotherapy may experience a serious primary infection or reactivation of a latent infection, fulminating encephalitis, and result in rapid death. Pulmonary toxoplasmosis may be present in conjunction with CNS infections. The presenting condition, the organism can spread to any organ. Toxoplasmosis via organ transplantation, so this has happened in the past. In the case of seropositive transplant recipient, immunosuppressive treatment to prevent the organ rejection may reactivate a latent infection in the transplant recipient. Toxoplasmosis in someone with a fully functioning immune system is typically not treated, but then there's some drugs that are available for people who are immunocompromised. The drugs are not effective against bradyzoites in cysts located in the muscle and brain tissue. So it's not going to kill the organisms in the cysts. It's going to only kill the migrating organisms. So T. gondii has two life cycle stages, tachyzoite and bradyzoite. Tachyzoite can invade any nucleated cell and are actively motile in reproducing forms. They're crescent-shaped and about 4 to 6 micrometers long and have a prominent nucleus. Bradyzoites are the slow-growing asexual forms found in cyst-like structure during the dormant phase of infection. So here's tachyzoites of T. gondii. Modes of transmission: water, ingestion of undercooked meat containing cyst-like structure with bradyzoites, congenital transmission, and inhalation from cat litter or garden. Risk factors: primary risk factors for acquiring, cleaning a cat litter box or gardening without gloves, and eating raw or undercooked meat or unwashed vegetable and fruit. Here is the life cycle, so you can pause the video and take a look at it. Laboratory diagnosis, immunological, and molecular methods are available. And now we're going to switch gears to the opportunistic intestinal apicomplexa. Cryptosporidium. So Cryptosporidium is recognized for causing self-limiting GI infection in immunocompetent hosts. One of the major issues with Cryptosporidium, and you may have all heard of Cryptosporidium before, is that doesn't really cause a lot of symptoms in the fully functional immune system people, those immunocompetent people, but it can cause some pretty serious and life-threatening infections in the immunocompromised, so the ones that have a decreased immune system function. Now, the thing about this is it requires water treatment plants to have ozone because typical cleaning methods and typical methods of disinfection don't work. This thing is readily transmitted in public pools because chlorine doesn't kill it. So if you swim in a public pool and there was like an accident with feces and the feces happened to contain the Cryptosporidium in it, you're not protected because the chlorine does nothing for it. You actually have to have an ozone generator to be able to disinfect samples of water. Now, our water treatment facilities usually do have this, but water is not continuously treated with this unless there's evidence of the pathogen in the water. Alright, that was strange. It all of a sudden popped up and stopped the recording. So continuing on, as I was mentioning, you need special water treatment methods in order to treat the water appropriately. Identified as opportunistic pathogens in immunocompromised hosts, particularly those with AIDS. Obligate intracellular parasites transmitted by ingestion of the infected oocysts, the fecal-oral route. Most infections are reported in the summer when there's an increased water recreational activity. Foodborne infections have been associated with ingestion of raw foods or unpasteurized drinks. Most common species found in humans would be Cryptosporidium hominis and Cryptosporidium parvum. Cryptosporidiosis is the leading cause of waterborne disease outbreaks in the United States. Outbreaks in daycare centers and from the environmental contamination of municipal water supplies have been reported. In the 1980s, cryptosporidiosis was identified as a major opportunistic pathogen infection in patients with AIDS and classified as an AIDS-defining illness. In immunocompetent patients, the organisms can cause a transient, profuse, watery diarrhea, along with mild to severe nausea and vomiting, headache, and cramps. The onset is rapid, with 3 to 7 days after ingestion of the oocyst, but the infection is self-limiting. Symptoms resolve in several weeks, but infections can last up to 1 month. So when I was like 6 or 7 years old, there was this massive outbreak of Cryptosporidium in Milwaukee. I did provide a video link to the details of that outbreak, but I remember I was in one of the communities that was impacted, and I was living in Milwaukee with my family. We were renting a townhouse in the north side of Milwaukee, and all of a sudden my brother and my dad got super sick. So it was a huge scare. In school, I remember walking around, and the bubblers all had signs on them that we weren't allowed to drink from the bubblers. My mom would like boil water and then like reboil it and like filter it extra. And she would boil water for like 2 years after the infection actually was over. So I remember that being like a major part of our childhood. A lot of people died from that, and I remember family members of some of the kids that I went to school with became really ill too. So just kind of a crazy time. But go ahead and watch that video to learn a little bit more about that outbreak. Infection begins in the small intestine, may spread to the large intestine. The first infection occurs in early childhood and is symptomatic, profuse watery diarrhea. Subsequent infections are mild to asymptomatic. The organism alters osmotic pressure in the gut, resulting in influx of fluid. Excessive fluid loss equals dehydration plus electrolyte imbalance. In patients with AIDS whose cell-mediated immunity is compromised and whose CD4 count is less than 50 cells per microliter, the infection is more likely to be fulminant or life-threatening or spread to extraintestinal sites. Chronic cases, damage to intestinal permeability can result in decreased uptake of fluids, electrolytes, and nutrients, and you may see malabsorption syndrome occur. Chronic cases, no antimicrobial therapy is completely effective against this infection. There's a couple drugs that can suppress the infection, and there's a new agent that has been used. Diagnostic morphology is listed here. So here's some pictures of what Cryptosporidium oocysts look like. And here's some additional pictures. Recommended detection methods, which do not distinguish organisms to the species level. Modified acid-fast stain, that's what you see here, pictured. Antigen detection tests, direct fluorescent antibody tests. And moving on to Cystoisospora bellii. So formerly just isospora. It's an opportunistic pathogen. Acute infections are clinically indistinguishable from Cryptosporidium. The infection is self-limiting, usually resolves in several weeks in an immunocompetent host. Asymptomatic or low-grade fever, headache, diarrhea, and colicky abdominal pain. More serious in immunocompromised patients, watery diarrhea, concurrent weight loss, or chronic infection. Treatment, a couple different drugs are available. This is what that looks like. And here's a few more pictures of it. Cyclospora. Transmission would be contaminated food and water. Humans are the only known host. Most commonly encountered in immunocompetent patients, may be considered an opportunistic infection in patients with AIDS. Symptoms vary based on age, the infective dose, and host immune status. Incubation period approximately 1 week, and then causes frequent watery but non-bloody stools that may alternate with bouts of constipation. Other symptoms, flu-like before the onset of diarrhea, and other symptoms are listed. In immunocompetent hosts, the symptoms are self-limiting, persist for several weeks, but may occur in relapsing pattern for up to 2 months. Immunocompromised patients, they're symptomatic for as long as 4 months. In some patients with malabsorption, they're caused by inflammation and damage to the intestinal villi. A few cases of extraintestinal infection. In endemic areas, infections are common in children 2 to 10 years of age, and most infections resolve spontaneously. A few drugs are available for treatment. Symptoms usually abate within several days after treatment is started. Here's a picture of that one. Microsporidia. So Microsporidia is a collective name for a category of parasites in more than 200 genera and 1,500 species. Obligate intracellular parasites are common to invertebrates and other animals. Originally considered protists, they have been reclassified as fungi based on chitin present in the spore wall. There are at least 9 genera implicated in human infections. Often linked to HIV infection, they have been identified in organ transplant recipients, older adults, and patients with traveler's diarrhea, capable of infecting a wide variety of human organs, including the intestine, eyes, muscles, liver, kidneys, and CNS. Symptoms differ with the species and the organ infected. Intestinal infections are most often caused by those 2 species. Infection in immunocompetent hosts is characterized by diarrhea, cramps, loss of appetite, and fatigue. Dehydration and weight loss are sometimes seen. 4 to 8 liquid stools a day. Symptoms may persist for up to 8 months with spontaneous exacerbations and remissions. In patients with AIDS, symptoms are more severe, as is listed. And then there's a few different drugs that are used for treatment, and disseminated infections have also been reported. Microsporidia can be found in various types of specimens. Electron microscopy must be used to identify the species of the organism. Stain with formalin and preservatives, preserve feces using different types of stains. Small size of the spores, however, makes them easily overlooked. Spores range in size from 1.5 to 4 micrometers. Calcofluor white can be used to screen specimens for microsporidial spores. And then here's how tiny those spores are. And here's other images of the spores. And here you can see them blown up quite a bit.